In the previous cirrhosis lecture, etiologies, we talked about how you might end up with cirrhosis and what you should look for in the clinical vignette to help you decide what is the etiologies of this person's cirrhosis. Most of the time, it's going to be alcohol and viral hepatitis. In this lecture, I want to show you how you identify someone with cirrhosis and then what you need to know about the complications of cirrhosis. A lot in this lecture, and there's actually 4 videos in the intern content below that covers the same amount of material. So I'm going to go very surface level here, only the stuff that you have to know. So I'm going to use this model. Cirrhosis is of the liver, and it's the dysfunction of the liver, either the synthetic function or the metabolic function, that leads to symptoms. All right, what does the liver do? First, the liver makes bile. And in bile is both bilirubin and bile salts. If the liver can't work, it can't excrete bilirubin bile salts, you are going to be yellow and itchy. That is jaundice and pruritus. The liver makes proteins 2, 7, 9, and 10. If you can't make clotting factors, factors 2, 7, 9, and 10, and those are the ones you have to remember, 2, 7, 9, and 10. And the mnemonic is 2, 7, 9, and 10. That's why I'm repeating 2, 7, 9, and 10. If it can't make clotting factors, the patient's going to bleed. But the way this is going to come up in a cirrhotic is that there's going to be an elevation in the INR. The liver makes albumin. And in cirrhosis, the albumin will be low. And the liver processes toxins, ammonia. And if the liver can't do its metabolic work, it can't clear toxins, and toxins accumulate. In this case, we're talking about hepatic encephalopathy. The first complication of cirrhosis we're going to discuss. We haven't completed the picture of what a cirrhotic looks like, and we'll get back to that, but I want to talk about ammonia. The pathology of hepatic encephalopathy is in ammonium in the brain. If the body can't clear ammonia, then ammonium accumulates in the brain and you get an encephalopathy. The patient is going to be just that. They're going to be confused, altered mental status, and there will be asterixis. Asterixis is described as the flapping tremor. What's actually happening is the person is trying to have sustained contraction. And for whatever reason, when the ammonium builds up, there's a loss of the connection from the brain to the muscles. So they lose tone. They're trying to maintain tone. They let go, regain, let go, regain. And that develops the flapping tremor. Confusion in a flapping tremor is indicative of hepatic encephalopathy. The diagnosis is clinical. Do not get an ammonia level. The amount of ammonia in the blood does not correlate with the ammonium in the brain. If you know they're cirrhotic and they're confused with asterixis, it's hepatic encephalopathy. The treatment is with lactulose. You eliminate whatever nitrogen you can through the gut. You may also back this up with rifaximin and zinc. The liver also is going to metabolize estrogen. And there's the metabolism of estrogen that happens to give the cirrhotics their appearance. If you have excess estrogen, you're going to end up with things like gynecomastia, palmar erythema, and spider angiomata. But a lot of the stuff that you notice with a cirrhotic, except for them being yellow, comes from the portal vein. If you imagine a big dam here, if you have an obstruction to flow, and this conduit is the only way for blood to get out of the portal system, out of the gut, it's the one way out, and you plug it up, this is going to increase. This is going to distend, and the pressure in here is going to rise. This is called portal hypertension. And And portal hypertension is going to have a number of consequences, and this is where we're going to go for the rest of the lecture. Portal hypertension is going to cause thrombocytopenia from splenic sequestration. It's going to cause ascites, and it can potentially lead to varices, that is, portal cable shunts. If you can imagine, in embryology, you have these connections between the portal system, the gut, and the cable system, the vena cava, the systemic system. And those close down because you don't want them to be connected. But there's technically still connection between them. If the portal pressures get high enough, they reopen. That happens in the way of hemorrhoids, caput medusa on the belly, those ones next to the renal veins or something like that that no one sees, no one cares about, and the varices. Varices is the next complication I want to talk about. Varices is just one of the portocable shunts. And it happens as a product of portal hypertension, and it happens in the esophagus. The patient is going to present in one of two ways. They will either present the way they're supposed to on an asymptomatic screen. That is, you do an endoscopy and see them. Or they're going to present as a vigorous, deadly GI bleed. And these bleed fast and hard, like vomiting blood from both ends. The diagnosis is made by endoscopy. And the treatment, if they're bleeding, you can band them. But long term, those bands are going to fall off. So what you need to do is reduce the portal pressure. You reduce the portal pressure by giving them beta blockers, nadolol or propranolol. But if they come in bleeding, you need to stop the beta blocker and do something else. Band them with an endoscopy to save them. They also need ceftriaxone and octreotide. More on ceftriaxone in a bit. Octreotide reduces the portal pressures acutely. If the person has bleeding varices despite the beta blockers, if the portal pressures are leading to the thing that's going to kill them, these varices, what you can do is a TIPS procedure. You essentially bypass the liver. You literally stick a plastic tube from the portal vein to the hepatic vein or the vena cava. You bypass the liver, you decompress the portal system, but you also bypass the detoxifier. So if you perform a TIPS procedure, you're likely to induce hepatic encephalopathy. So there has to be a very good reason why you're doing the TIPS, and that is to prevent esophageal varices from killing the person. All right, back to portal hypertension. Thrombocytopenia we know about, we talked about the varices, and now we're talking about ascites in general. And I have to take you back to first year med school for this. Bear with me, I'll make it simple. Remember, the flow across a membrane was equal to some coefficient times the arterial pressure, the hydrostatic arterial pressure minus the hydrostatic interstitial pressure, minus the oncotic pressure of the arteries minus the oncotic pressure of the interstitium. Remember all that equation? Neither do I. But if you actually remember what that was about, was that the hydrostatic pressure pushes fluid out of the blood vessel and oncotic pressure pulls it back in. And for the most part, those are the only two forces that mattered. When it comes to ascites, what you have to decide is what is causing that fluid in the belly. That's what ascites is. Ascites is fluid in the belly. What is causing that? Hydrostatic forces, or is it something in the interstitium drawing fluid out? That is to say, is it just a bunch of water that managed to leak through engorged vessels, or is it a bunch of stuff mixed in with that water that makes it more something like cancer or infection? The way you do that is with a SAG. Ascites is fluid in the belly. And you're going to separate it into portal hypertension related. That's why we're talking about it here. And non-portal hypertension related. The way you do that, the diagnostic step, is paracentesis. You effectively obtain a biopsy. And in that biopsy, you get a SAG, serum ascites albumin gradient, which is the serum albumin minus the fluid albumin. If the fluid doesn't have a lot of stuff in it, the fluid albumin will be low. This gradient will be high, and it means there's mostly water in the belly. Portal hypertension related means the SAG is greater than equal to 1.1. This gradient is high, means portal pressures, only water. That's going to be cirrhosis and right-sided heart failure. If instead the SAG score is less than 1.1, it means that there's a lot of stuff or albumin in the fluid, bringing this equation closer to zero. A lot of stuff means cells. Cells means infections like TB and cancer. Malignancies that can do this are the ones that are already in the peritoneum, ovarian and pancreatic, but others can do it. Now, of course, there's more to this than these diagnoses. Budd-Chiari, hepatocellular carcinoma can lead to portal hypertension. Bowel obstruction, nephrotic syndrome, and protein-losing enteropathies can cause problems with the fluid albumin. But these are the four I want you to recognize. The person who has ascites is going to present with bulging flanks, shifting dullness, and a fluid wave. Remember, this is all about fluid that's in the peritoneum, free-floating fluids. When they lay flat, all the fluid layers out. If you start tapping on top, you'll get tympany. And as you move towards the fluid, you'll get dullness. But then you have them roll on their side, and all of a sudden, what was dull is now tympanitic because the air has risen and the fluid has sunk to the bottom. Bulging flanks, shifting dullness, and fluid wave. The way you can actually see this is on an ultrasound or a CT scan. You see a bunch of fluid. That's not very hard. The diagnosis is made with the paracentesis, so you can do the SAG score, but also get culture data, gram stain, cell count, protein, etc., to diagnose what's in the fluid. In a cirrhotic, which you will treat the ascites with, is a combination of furosemide and spironolactone. Everybody needs to have fluid restriction, 2 grams of sodium chloride, 2 grams of water, and every once in a while you may need to do a therapeutic paracentesis. But you do the paracentesis for another reason, because in that fluid you might have an infection. And that's the next complication, spontaneous bacterial peritonitis. The pathology is an infection that happens spontaneously. That's why it is called spontaneous bacterial peritonitis. It's a translocation of organisms into the fluid. For whatever reason, it is a combination of strep and or gram-negative rods. The patient can present completely asymptomatic. Again, why it's called spontaneous. So anytime a patient presents to the hospital, anytime there's a change in a cirrhotic of any kind in any way, altered mental status, bleed, pain, fever, what you should look for on the test is fever and abdominal pain. But know that anytime there's any change in a cirrhotic, and if they're presenting for any other reason than saying, hey, I'm here for my scheduled paracentesis, I feel fine, you need to send the fluid off for SBP. The diagnosis is made with a TAP, a paracentesis. And what you're looking for are polys greater than 250. If you have greater than 250 neutrophils, the treatment is IV ceftriaxone or another third-generation cephalosporin. And if the total protein is less than 1 of the fluid, they need a prophylaxis with a fluoroquinolone, such as norfloxacin or ciprofloxacin. If you've ever had SBP or your total protein is less than 1, prophylaxis with a fluoroquinolone. Now, there's a thing called secondary bacterial peritonitis where you tap the person and the culture does come back with lots of different organisms. That means you have a perforated bowel and you need to do exploratory surgery. In the case of spontaneous bacterial peritonitis, the culture data, unlike most of your infectious processes, generally comes back negative. You treat the white count, the neutrophils greater than 250, and do not wait for the culture. And if the culture comes back negative, you still treat if the polys were elevated. Secondary bacterial peritonitis, lots of organisms grow, got to go and do surgery. No organisms grow, but there's greater than 250 polys, that's SBP, treat with ceftriaxone. The last complication we need to talk about is what happens when that inflammation leads to a cancer. And that cancer of the liver is hepatocellular carcinoma. The pathology is going to be chronic inflammation, and there's two ways that this can happen. The same thing that led to the cirrhosis in the first place, or hepatitis B. That is to say, people who get hepatocellular carcinoma must have either cirrhosis or hepatitis B. Why is that? It doesn't matter. A person can get hepatocellular carcinoma only by having hepatitis B. Otherwise, they must be cirrhotic first. The patient is generally asymptomatic and is caught on an asymptomatic screen. The diagnosis is made not with a biopsy, but first you screen with a right upper quadrant ultrasound, looking for a mass, and an AFP. The confirmatory test is not a biopsy. Confirmatory test is a triple phase CT. And a triple phase CT does this. The cancer is supplied by arteries. During the arterial phase of the triple phase, cancer lights up. The liver is supplied by the portal vein, so it does not light up in the arterial phase. It does light up in the venous phase. The cancer does not. That washout is confirmatory for hepatocellular carcinoma. The treatment of hepatocellular carcinoma, I think, goes beyond the level that you need to know, but just know this. If it's small, it gets resected. If it's a little big but not too big, it gets transplanted. And if there's too many or they're too big to transplant, you can use radiofrequency ablation or chemoembolization. Okay, let's take it back to where we started. To identify the cirrhotic, you're going to find the person who's got a big swollen abdomen, gynecomastia, red palms, spider angiomata on his skin. The labs are going to show you a thrombocytopenia and an elevated INR. Maybe an elevated bilirubin. The AST and ALT will be normal because they've burned out. The person's going to bleed, be yellow, and be itchy. You only make the diagnosis of cirrhosis on a biopsy. You can get imaging, ultrasound, or CT scan that are suggestive that show a fatty liver or nodule or whatever, but you cannot diagnose it without a biopsy unless you have an absolute clinical diagnosis. But once you make the diagnosis of cirrhosis, whether on biopsy, which is not often required, or clinically, you then have to expand your coverage and start talking about the complications that can arise. Hepatic encephalopathy, look for asterixis, treat with lactulose. Varices, screened for with an endoscopy, treated outpatient with nadolol. During an acute bleed, you stop those, ceftriaxone nitratide, tips if refractory. If there's ascites, you need to do a paracentesis to get a SAG score to make sure it is from cirrhosis. SAG greater than 1.1, likely cirrhotic or portal hypertension related, less than 1, cancer or TB. Every time you tap somebody, you need to make sure they don't have SBP. Polys greater than 250, give ceftriaxone. And then finally, if a person is cirrhotic, they need screening with ultrasounds and AFPs to look out for hepatocellular carcinoma and a triple phase CT to definitively diagnose. And that is cirrhosis and its complications.